this is the introduction. This has to do with the 400 that Deanne mentioned. There are three populations that we measure. We do not have child abuse data. You're going to hear about how we're going to get it, but we don't have it now. What we have is service data on hospitals. How many babies born in your hospital? How many kids under age 3 in the emergency department for injury? How many kids under age 3 hospitalized in the patient in there? And it's just frightening to me. 344 babies born a day, 95 kids under age 3 a day going to an emergency department, 4 hospitalized. And of those that are hospitalized, there's a pattern to that that suggests that those 4 have a high rate of being hospitalized in an intensive care unit or on a burn unit. Next slide. This is my superhero of life. Ambroise Tardieu is the French physician that started some of the forensic medicine stuff, where he did autopsies on children. They did everything then. They didn't have all the specialties. And he wrote on child abuse, child neglect, child sex abuse, fatal child abuse in 1860. Now, he wrote it in French, but there were people that spoke French and other languages, and essentially nothing happened for 102 years. Now, that's not quite true. Between him and Henry Camp, who discovered child abuse in Denver in 1962, there were articles by radiologists, and they had all these kids who had all these fractures that weren't explained. And so they may well have known a lot more than they put on their paper, but for the most part it turned out it's just a metabolic or some kind of a syndrome, why these kids have these fractures. Next slide. And so here is coming up from Dr. Henry Kemp, interesting, stubborn guy. In his article, when he mentioned his 3rd child who died, he said, "This child died after we sent him home again." He's basically saying we blew it, and that kind of honesty is something that we need. So let's just do the red ones. It's 78, start child fatality review here in Los Angeles County, and there's a logic to it. It's multi-agency, it is criminal justice and human services. It has people that don't even like each other necessarily on the same team, but when you're talking about the death, it makes the process much more vigorous if you let some various people in the room. So then in 1981, we had a precursor of the present hospital network, and it was frighteningly successful. We had, by a screwed up data system, 1,000% in increase of reports by hospitals. We started with 6 hospitals with scan teams, and we have a whole lot more doing that now. But I can't clean up the data because of the concern about possible legal issues. The process was ended. And it was ended with but we're all going to do this stuff. And I mostly believed that a couple of years ago, maybe 20. The fact is we lost something and we didn't build it back yet, but we shall. We're on our way because there's new laws that are giving us more room to do that. So now this is where we are in LA County Network. We're going to activate LA County. Next slide. So why do the hospitals? The hospitals have people who know injuries, and they know newborn infants and toddlers. They aren't everything. There are kids who never get to the hospital, but they are most of what we've got. Anyhow, next slide. So here is what LA County looks like, where the hospitals are in clusters. Next slide. You have a handout of this. You should have a handout of this. This is the list of hospitals in LA County that are part of our network. This is not all of the children served, but it's 90% of the births, 90% of the emergency room, 97% of the births, something like that, 99% of the inpatient. Next slide. And this is if you choose stuff like this, you start from the big hospitals. That's Children's Hospital LA and then Children's Long Beach. They are busy places, but so are a lot of other people. As you add hospitals to the network, you start picking up other resources. Do they have a pediatric intensive care unit? Do they have a scan team? And as you move to the right, you can see the list gets longer. Next slide. And this is part of our exercise, I think, is to note this is a new issue. There was no child abuse until the 1960s. In terms of official statements, there were cases of people that did things. But in terms of government and large programs, it's fairly new. 70s, 80s, 90s was when child death review began to become part of it. Anyhow, what we need to do, the single thing we need to measure the most is measure ourselves. We don't do that part. How are we doing? And if we're not doing right, why? I'm trying to understand. Next slide. And here is a way ahead of dissent. There's the final report in the Commission to Eliminate Child Abuse and Neglect. They got stuff in there. They spent a lot of time and money making that happen. And then there's a dissenting report written by a judge of the Chicago Cook County Juvenile Court. And to me, if you read both of those, you get a better picture of what the problem is and what the answer is. Next slide. This is where we're going to go statewide. This is a big jump, but we have some people who can pick it up if they will. Next slide. And in the future, we're going to end up, we have a separate domestic violence fatality review, child fatality review. We talk to each other, we get along, we've had meetings together, but fatal family violence just makes more sense than these are the adults and these are the kids separately. Next slide. This is what we may do. We started with all the hospitals, all the child fatality review teams. We're going to take in all the programs for child grief, anything within that county that people are learning how to cross lines, and then we're going to connect the counties with each other. We have to do this, if only because there are multi-county cases. And this should not be an honor system, though we have a system to handle those cases. That doesn't. Anyway, next slide. So this is something about what we have now in LA County. You're going to hear more about that today. Next slide. Anyhow, so now we're coming to software. We need a way of capturing the data on child abuse, and we don't have it. There are problems with the name of the hospital in the present system that exists. So we're going to build a separate software package. Ruby and Joseph, you want to come over here? And Ruby and Joseph are going to take us there. Ruby is a Child Protective Service social worker, goes out with the command post nights, weekends, has a bullet hole in her car. I mean, this is exciting stuff. Joseph is just this incredible, sweet, unassuming guy that knows a whole lot about, particularly about the things we're all carrying around in our pockets and purses, how to connect people with mobile devices. And they're going to explain what they have built so that hospitals, at least hospitals, can know how many reports did you make and what did you report. Ta-da!
Thank you, Dr. Durfee. Hi, my name is Guillen. Dr. Durfee mentioned. I work for Command Post, but I also am a researcher for Dr. Durfee. I've known and worked with him since 2000. I'm also a hacktivist. I have a computer degree, computer information systems. I've hacked for the White House, Facebook, Google. I continue to go to hackathons. I just went one 2 weeks ago. I'm going to San Francisco in 3 weeks. Well, I'll be hacking with 500 hackers. And it's all related to child welfare and child abuse and violence. So let me pass it to Joseph. He's been in the industry for child welfare education and special needs children for 20 years.
Thank you. I get the privilege of talking about something that we believe is really going to impact and support our greatest, or who we feel are at greatest risk victims, and that's small children. What I'm going to be talking about is what the tool is, child abuse reporting tool, what it does, why are we using it, who are the creators behind it, and what has been the movement for that, and how you guys can participate and help out. The software is a cloud-based application that allows us to access it through computers and handheld devices. It empowers us to reporting statistics and being able to utilize that to understand what's going on in our communities. It's designed specifically for the medical profession, and it will be fully HIPAA compliant. Now we actually have the ability to capture real-time data on child abuse as it's going on. We also can utilize that for agencies and municipalities to help them work and share the information they need to respond more appropriately. And now, for the first time, as I said, it actually captures real-time data within the hospitals that you're working in. There's a cost associated with child abuse. Not only to the victim, what's happening to the victim, services, interventions, the families. Over the lifetime, it's equal to someone with type 2 diabetes. And that cost, it's a medical cost, it impacts us all. We understand that in regards to reoccurrence of abuse, reoccurrence generally happens or often happens within families. It's not isolated specific just to a family, single family, but we see a reoccurrence within that generation that can occur, and we want to break that cycle. By identifying and reporting that, we're able to break that cycle and interrupt the reoccurrence of that. We know that unfortunately, if it's not interrupted, that the violence generally tends to increase and it becomes more aggressive. Through data, we're actually now able to capture that information, use that data as a predictive tool to look at future events and to try and interrupt that cycle. And it's the right thing to do. We're all in this room because we believe in what we're doing and trying to intervene and support children. We want to make sure we continue that. Well, we can now with real-time data. It's about information and having access to that. We can now use the graphs to visualize and interpret the data so that you can understand what's happening, as well as print, transmit, email, the same forms that we've been using for years, but now via the internet using PDFs. We have the traditional form of the suspected child abuse report form that we've all had, we've all seen, we've all used, with all the same data fields, all the information that we need to collect to support, to provide. Well, now we have it on a web-based form with all the same fields, all the same information, able to get it out faster. Along with that, we also have, which is the medical annotative form. The importance of this that was created by Dr. Durfee is that it gives a deeper understanding of the impact of that single event to that child. So we're able to understand what happened, what's going on with the head, shoulders, knees, and toes. Was it abrasion? Was it an incident? Broken limb? That information is necessary. It's important because those that are responding need to understand that level of injury. We've been now being able to create that in web-based form as well, so that gets out. Talk about the team real briefly. It's a collaboration between ICAN and Humanistic Technologies Incorporated, HTI. HTI is social workers, data engineers, software developers, and MBAs that wanted to make a positive impact to our greatest victims, those that are defenseless. In doing so, we now are able to complete the mandated reports that we're already having to do, but more efficiently. We can also analyze that data that we have, make sure we're providing the resources and support where it's needed, and that general analysis, we can see within the hospitals what we're dealing with and help kids be safe. The reality, using the data and analyzing the data, we're able to use that as a predictive tool and potentially prevent future incidents of abuse. That's what we really can hope for, is really just making an impact. If children get hurt, they're going to get hurt, but it's what we do when we get them. What can we do forward to supporting them and preventing any further incidents of that? We have some graphs using the child abuse reporting form as well as the medical annotative form so that you can generate the information within your sites, the hospitals. Now, what we need your support. We need your help. We need to be able to pilot this in a hospital in real time, on site. So that way we can go through it and see what we need to do to better improve it so that we are making that positive impact. What we're giving back is that you'll be able to have access to the site, to the software when we launch it for 90 days free, be able to use it, really make sure we get a great understanding of it. Also, all the training that is needed for staff and personnel that are going to be using it, being able to have one-on-one training for them, as well as being able to generate your own standards and reports for each facility. Now, on the table, there's handouts. please take one. We have more at the table outside. At lunchtime when we're done, please come by. We'd love to show you what the software looks like, be able to let you play with it. It's actually very accessible, usable. I needed it for me to be able to understand it. So that's why we designed it that way. So thank you for your time.